All right, so part 2 of this, automated external defibrillator. The most common conditions resulting in arrest are VFib and VTAC. As I mentioned, VFib, you could consider a room full of kindergartners with an espresso and a puppy, and they're just going nuts. And we use a big giant taser to tase everybody in the room, knocks everybody down, and then they hopefully will get back up and do what they're supposed to do. VTAC is a hijack. One of the cells or a couple of cells in the heart have hijacked the electrical conduction system and have basically said, we're taking over, we're going to be stronger than everybody else, and we're going to make you guys all beat when we want to beat, and that might be 250 times a minute. It's very organized, but it's very fast. A couple things to consider with AED safety. Do not defibrillate soaking wet patients. If you just pulled them out of the pool, have somebody dry them off while you're doing some CPR. Move them away from the water before you would consider defibrillating them. Do not defibrillate them if they are touching anything that is metal and other people are touching it. So if the person's touching the metal cot rail and you're leaning up against the cot frame, you too are going to be defibrillated. If the person is on a tin roof or a metal roof of some sort, don't defibrillate them while you're kneeling on the roof next to them. Remove anything underneath that would typically go underneath the defibrillation patches before applying them. So if they have nitroglycerin or other pain patches on, remove those. They will catch on fire if you get them defibrillated. Necklaces, bras, whatever needs to come off. It needs to be pad to bare skin, nothing in between. If they're a ridiculously hairy person, you may need to have a little disposable razor in your defibrillator kit and mow some of that hair off of there before applying your patches. Say and visually clear the patient before defibrillating. You say, 1, I'm clear, 2, you're clear, 3, we're shocking, something along those lines. But as you're saying it, you're also looking around, make sure nobody's touching. They recommend even disconnecting your bag valve mask or moving the bag valve mask off of their face before defibrillating, because oxygen can increase the possibilities of the patient having yes, oxygen enhances burning capabilities. It will not explode, but it just as a matter of being extra safe, it's probably not a bad idea. So 1, I'm clear, 2, you're clear, 3, shocking. So we're just double checking, and everybody's responsibility to pay attention when, and normally the defibrillators are also making all kinds of racket right before you're ready to shock them, meaning that it's fully charged. So, if a patient, if a provider gets shocked, it can be bad enough that it actually can cause that person's heart to stop as well. Rare, but it does happen. Defibrillation can be performed on a patient with an implanted device. So if they have an implanted defibrillator, if they have some sort of an implanted pump, maybe they have a pacemaker, you can defibrillate them. Most pacemakers, when they're implanted in a patient's chest, are put up by your left shoulder. So most of the time where we place pads is one up by your right shoulder and one down on your lower left rib cage. So in most cases, we're not covering it. You should try to not put a defibrillation pad over a pacemaker if you don't have to. Those pacemakers are roughly silver dollar size, and I realize that now that's probably dated me, but so say around a 2 to 3 inch diameter. Usually it's almost round, and you can feel it right underneath the skin, and it may even be popping out just a little bit. So try to keep away from that if possible. Your AED's maintenance. Use a checklist as required by your service, whether that's every shift or once a week or something along those lines, that you're checking your supplies, making sure that it's charged. Do you have a spare battery if necessary? Do you have pads for both adults and kids? Maybe you want to keep a razor. Maybe you want to keep an extra set of pads for adults and kids. Maybe you want to have a towel or a washcloth in your kit so you can wipe down a wet person. So check that as required by your service. Typically they say at every shift. And then hopefully your battery is charged or you have a spare battery. AED batteries generally are pretty long-lasting, but they're not usually rechargeable in many cases. So if that's the case, then you need to make sure you have the appropriate extra support. Okay, so of course being prepared is key. So making sure that you don't have to all of a sudden go, oh crap, our batteries are dead, our defibrillator's not here, call another truck. Quality improvement that involved with AEDs. Most services, the medical director will review any AED calls. There has to be some oversight to make sure that things are going well there. Obviously you have to be initially trained. You're kind of getting your initial training now. You need maintenance training as well when you actually are going to work in EMS, when you are getting on a service, when you get a new monitor or defibrillator, when there are changes in protocols. And then a lot of places also require you every 30, 60, 90 days to do some sort of a skills competency check to make sure you're competent. Case reviews, a lot of times they get reviewed by the medical director and they'll meet with the providers or the service and talk about what they found. And now analyzing trends, like it's taking us 10 minutes to get the defibrillator even applied to the patient. Why is this a problem? And then it helps strengthen our chain of survival. AED is a very, very good tool. It's advanced cardiac science a long ways. So to coordinate CPR and AEDs, you only interrupt CPR when absolutely necessary and for as short a period as possible. CPR must be paused for rhythm analysis and defibrillation. That is the only times that you stop pushing on the chest. So when it comes up and it says, analyzing now, stand clear, or something along those lines, you get off the chest and do not touch the patient, because even a small vibration coming from you touching them can throw this thing. So you stop. If your defibrillator is newer, and a lot of newer ones will charge up and will analyze and then charge up and deliver the shock within seconds. If you have an older AED that takes it a little while to charge up, it's probably a good idea to do chest compressions in between while it's charging up. And then once it's charged up, then you get off the chest and deliver the shock. Once the shock is delivered, you are right back on the chest. We're not playing around. We're not checking this. We're not looking that. Once that shock is delivered, back on the chest and press. Just because you defibrillated them does not mean they're going to have a pulse back that instant. It actually usually takes a matter of a few seconds to a minute or so to start to see a pulse return. So getting back on the chest, pressing on the chest, is the best thing you can do to keep the circulation moving. So our patient assessment. Perform our primary assessment. If the bystanders are doing CPR when you arrive, ask them to stop. Verify that the patient is pulseless and apneic and they're absent of any other signs of life. You should do this for no longer than 10 seconds. So for 10 seconds, you're watching them, see if they're going to try to gasp for a breath. You got your fingers on their pulse trying to determine, is there anything there that we need to not? Because occasionally people mess up. They start pressing on a patient's chest, pushing them, doing CPR on a person who does have a pulse. We're going to bare the chest. When we say bare the chest, it is bare. It is not a bra left in place. It's not T-shirts left in place. Those are things that will help kindle a fire once you defibrillate your patient. So bare the chest. If necessary, shave the areas where the pads are going to be placed. If you're talking a pediatric patient, so one between about the ages of 8 and 1, we may use pediatric patches on that patient. We don't want patches to touch. If the patches touch, then the energy short circuits across there. So use pediatric pads on small kids and use adult pads on anyone over really the age of 8. Or if you have a very large 8-year-old, you may want to consider using the adult pads. Pediatric pads have a little attenuator in there which actually brings the electricity down. If you look at page 486 in your textbook, there's an example of a couple of pads there. There's an adult set of pads in picture A plugged into the defibrillator. and there's a set of pediatric pads in picture B that has a little pink teddy bear. That's the connector, and that means pediatric pads. Sometimes it's a yellow teddy bear, but that drops the energy down, so it's not as high of an energy level. Turn on the AED, attach the pads to the cables if necessary, and then apply the pads to the patient and attach the monitor. Stop CPR, and if necessary, hit analyze. If it does its own analysis, you just stay on the chest until it tells you to stop, and it's going to analyze. If it says shock advised, then it will charge up and you will deliver the energy. Make sure you clear everybody anytime that it's going to analyze, or you're going to push the button to shock. Nobody can be touching. Preferably remove the bag valve mask if necessary. Immediately begin CPR after delivering the shocks. Reassess that patient after 2 minutes or 5 cycles of CPR. The defibrillator will count it down for you. So it does this on a 2-minute cycle. So it's going to tell you once your 2 minutes are up. So you may have to stop when you're on compression 26, 27, 28, 29, something like that. You might not get that set of compressions in or that breath in. If you don't get your breaths in while it's analyzing, after it's done analyzing and it's charging up, maybe give them a quick breath or two and then pull that bag back off. If the AED finds there is no shockable rhythm, it will tell you that no shock is advised, and this is in a couple of different scenarios. One, pulseless electrical activity. That's a rhythm that looks normal, but there's no muscle going with it. So it's completely electrical, the muscle is out of the picture. Or asystole, which is a flat line. In those cases, resume CPR immediately. So you're not going to deliver a shock. It tells you no shock advised. You're back on the chest, pushing, and you're breathing. When providing CPR, compressions must not be interrupted for any longer than 10 seconds. Compressions of at least 2 inches deep for an adult and 1/3 the depth of the chest of an infant or child. The rate should be at least 100 per minute for an adult, probably closer to 120 for an infant. Rotate your personnel through compressor position on a regular basis to prevent fatigue. Personnel should try to only do chest compressions for 2-minute cycles. So you do the full 2 minutes, then somebody rotates into your spot and maybe you ventilate, or somebody else rotates into your spot and you do the defibrillator. So if you've got the hands, rotate people as often as possible. If there's only 2 of you, you do compressions for 2 minutes, your partner does compressions for 2 minutes. You do compressions for 2 minutes, your partner does compressions for 2 minutes. You think that you're doing fine. Scientifically, we know you're not. You're becoming weaker the longer you have to do that. It's very strenuous activity. If the patient begins to wake up or move, obtain your baseline vital signs. Continue to provide them with high flow oxygen if they start breathing on their own and the breathing is adequate. If the breathing is minimal or non-existent, then you have to continue to breathe for them with the bag valve mask. Load them up and transport them. You can keep the AED on them, and it may analyze them every couple of minutes, but go ahead and get them transported. Call for ALS if you haven't. If the patient has a pulse, manage the airway and avoid hyperventilation. So they may go to a non-rebreather. You may still have to bag for them. And if you have to bag for them, remember it's 1 breath every 5 to 6 seconds. Reassess that patient frequently. They are unstable, and we know from our rules of assessment, unstable patients get reassessed every 5 minutes. And if your system has a hypothermia protocol, then you would initiate that based off of those system protocols. So whether you're making them ice packs in the pits and groin, or cooling blankets, or whatever you have. If the patient goes back into cardiac arrest, stop the vehicle, resume CPR, and then analyze as appropriate. If you have the capability, the patient goes unconscious, you reach up, you check a pulse, they have no pulse, and you can press the analyze button, do it right then. That's great because it's going to allow you to get that electricity delivered much quicker. Deliver the shock if indicated, and then ride back on your cycles. So you got continue with 2 shocks separated. No, you're going to, oh, I get what they're saying. 2 shocks. So all your shocks are 2 minutes apart. You're 5 cycles. That's not a very good way to put it. So mechanical CPR devices. If you have mechanical CPR devices, these are things often called the thumper, the auto pulse, the Lucas device. There's lots of different devices here that you can use depending on your affiliations. Automatic CPR devices are usually some sort of a band that goes around the chest or a piston that's positioned in sandwiches between the top piston and the board underneath, and it presses on the patient's chest. It provides very consistent compressions, but often it's very difficult to work with. You have your couple of cardiac arrest videos that you should watch, as well as your AED video and your understanding the MI. So in chapter review, patients with cardiac compromise or ACS can have a lot of different presentations. It can be anywhere from just a little bit of angina pectoris, which lasts for a couple minutes and goes away with rest and a nitro or 2, to a cardiac arrest. Their usual complaints are pain or pressure or discomfort across the chest with difficulty breathing. Some patients may only have difficulty breathing. Some people think it's just indigestion. Between 10 to 20% of heart attack victims have no chest discomfort. Those are, remember, called silent MIs. Because of the possibilities of severe complications of heart problems, we have a high suspicion to treat patients with symptoms that may suggest cardiac compromise. So that's, again, we're going to pretend that it's the worst situation until proven otherwise. ACS patients generally need high flow oxygen concentration unless your protocols allow you to use to base your oxygen off of your pulse oximeter. In which cases, in most cases, if patients have a SAT 94% or better, we generally will just go with low flow oxygen as opposed to non-rebreathers. You may be able to assist a patient with their own nitroglycerin and or aspirin. Remember that there are certain guidelines to using both of those. To provide maximum chance of survival for patients in cardiac arrest, we've got to strengthen our performance in the chain of survival. So early CPR, rapid defibrillation. Remember, the heart is a simple pump that moves deoxygenated blood to the lungs and oxygenated blood to the body. And pressure within the cardiovascular system is critical for moving the blood. ACS is a blanket term that means a lot of different heart conditions. And although there are common symptoms of ACS, EMTs need to recognize atypical situations and err on the side of caution. Oxygen, nitroglycerin, and aspirin are key medications indicated in the treatment of ACS. However, the definitive treatment is transportation to a facility where they can open up that blocked artery. Most cardiac conditions are caused by arterial problems. Angina pectoris and acute myocardial infarction are caused by inadequate perfusion. And heart failure can be caused by either electrical or mechanical problems in which it can't pump efficiently. The most important element of cardiac arrest care is the administration of high-quality chest compressions. The American Heart Association's chain of survival describes the key elements needed for a patient's survival. AEDs provide early defibrillation in cardiac arrest patients to VFib and VTAC patients, and post-cardiac arrest care is essential element of cardiac arrest care, because if we just stop once they're resuscitated, the patient's very quickly going to deteriorate. Mechanical CPR devices can provide you with an extra set of hands in the cardiac arrest setting. So some things to consider. Difficulty breathing. What position is best for a patient? Difficulty breathing and a blood pressure of 100/70. While 100/70 isn't necessarily low, if they start to complain of dizziness and whatnot, we may need to lay them back. But if they have difficulty breathing, in many cases we'll try to put them in a semi-Fowler's position if they have a borderline blood pressure like that. If they can handle it, if they can handle sitting up, and sitting up is easier for them to breathe, great. Worst case scenario, the patient bottoms out and goes unconscious, we lay them back down. So chest pain and a blood pressure of 180/90. Usually we want to sit them up, sit them closer to upright. That's a pretty high blood pressure, so let's use gravity to our advantage and have it pull some of that blood down. Describe how to clear a patient before administering a shock. Usually it's a 1, 2, 3 approach. You're not only saying it, but you're looking, and if you need to, you flag somebody down and tell them get off. List 3 safety measures to keep in mind when using the AED. Not if they're wet, not if they're on metal, and make sure to not have anything between the pad and the patient. List the steps in the application of the AED in which you can do that. So your critical thinking question: a 78-year-old male has been complaining of severe shortness of breath for about 20 minutes prior to your arrival. When you arrive, you find the patient unconscious and not moving. What are your immediate priorities? If they are unconscious and not moving, that is when we kind of switch gears and we go to a resuscitation mode. We're going to check our patient real quickly. Maybe we're going to shake and shout. We're going to check for signs of life. Finding none, we would then bare the chest, begin compressions, begin ventilations as necessary, and then prepare to get the AED applied and analyzing.